All right. So yeah, welcome back to the Cholesterol Masterclass. This is session 3. Today we're going to be focusing on understanding medication options. If this is your first time joining us, if you missed the previous sessions, again, this is hosted by us at the Family Heart Foundation. If you missed any of the previous sessions, we are going to be sharing all of the recordings once the entire masterclass is completed, so you can stay tuned for that. All right, next slide. All right, and again, this information is all for educational purposes. It's not meant to be a substitute for your medical care. It's not meant to be medical advice. Make sure that you are following up with your doctor about any specific recommendations pertaining to the treatment of you or your family. Next slide. Again, just familiarize yourself with some of the features here. You can use the chat to ask any questions along the way. We'll be collecting those as we go, and we'll answer them at the end. Next slide. You can also use the raise hand function there under the reactions if you want to ask a question instead of typing it. Next slide. You can adjust the view. Feel free to keep your camera on or off. You can adjust your view in the bottom there under speaker gallery view. Next slide. And again, we want to thank Amgen, who is the sponsor of this masterclass, who made this entire masterclass possible. So big thank you to Amgen. Next slide. So again, we're going to start off with a couple of poll questions just to get you thinking about some of the things we'll be talking about today. So question 1 is, if you are on a statin, how often does the FDA recommend screening for liver function tests? We'll launch the poll here. So never, periodically, once a year, or every 2 years. Right. So this one is a bit tricky. The FDA actually says that liver enzymes should be tested periodically. They leave it a little bit vague. Dr. McGowan, who will be leading the session today, will go into this a bit more in the coming slides, but it is a bit vague there. So periodically is the right answer. Okay, next question. So if you're, oh, hold on a second. Sorry. So if your healthcare provider doubles your statin dose, so for example, if they increase your dose of Lipitor from 10 milligrams to 20 milligrams, about how much can you expect your LDL cholesterol to fall? The answers are 6%, 12%, 24%, or 48%. So if you're already on a statin, they double the dose. All right, looks like we have most of our answers in. So everyone who said 6% is correct there. Doubling a statin dose, we can expect an additional 6% decrease in that LDL level. There you go. Here. All right, so question number 3. Oh, you want to... All right, so garlic is as effective as low-dose rosuvastatin, which is the generic Crestor, in lowering LDL-C. Okay, looks like we have most of our answers in. So this is false. There are a lot of claims out there about various supplements that are being sold as cholesterol lowering, and garlic, as we'll see, actually raises LDL cholesterol, despite some of the claims that might be circulating out there. All right, and our final question is, lipoprotein A, or Lp(a), is a cardiovascular risk factor which can be lowered by which of the following measures? So either diet, exercise, statin therapy, or none of the above. Okay. So most everybody got this one correct. It is none of the above. So there are currently no medications which specifically lower LP little a. And diet and exercise also do not have any main effect on LP little a. That doesn't mean there's nothing that can be done about it, but there's no direct treatment for your LP little a. With that, I'm going to go ahead and stop sharing, and we'll introduce Dr. McGowan, our Chief Medical Officer here at the Family Heart Foundation, coming back to speak with us about currently available lipid-lowering therapies. So thank you very much, and thanks for joining us, Mary.
That's great. I'm just wondering, Eric, are you able to get rid of the share results, or how do I get rid of that?
So you might need to escape that on your screen if you still are seeing that. If you
am still seeing it. Let's see. I'm gonna go. I think. Oh, there we go. I can get rid of it. Okay. Thanks very much. It's great to be back. And today, what I'd like to do is recap a little bit from our first conversation, recap what the desirable levels for lipids and for LP little a are. We'll then move on to talk about the management of LDL, triglycerides, low HDL, and elevated lipoprotein little a. Our conversation today will really revolve around medications because, as you know, Mary Card gave you a great lecture last week on lifestyle modifications to improve these lipoproteins. After we talk about the management of these lipoproteins that I just referred to, we will talk about agents in clinical trials for LDL reduction, for LP little a reduction, and for triglyceride reduction. And then we'll end by talking about supplements and asking how supplements compare to rosuvastatin, which is a statin, in terms of LDL and triglyceride reduction and HDL improvement. So just to remind you about what the lipid goals are for individuals with and without ASCVD. And ASCVD, as a reminder, stands for atherosclerotic cardiovascular disease. This means a history of heart attack, stroke, TIA, which is transient ischemic attack, which is like a sort of warning stroke, peripheral artery disease, stent, bypass surgery. And so if you don't have atherosclerotic vascular disease, and this is sometimes called primary prevention, people who don't have vascular disease, we want your total cholesterol to be less than 200, your LDL or bad cholesterol to be less than 100, your HDL or good cholesterol. For men, we want it over 40, and for women, over 50. In terms of triglycerides, we want it less than 150, and ideally, the lower the better. So for people with atherosclerotic cardiovascular disease, the stakes are higher. And so we do want the total cholesterol to be less than 150. We want the LDL at the bare minimum to be less than 70. And for people with multiple risk factors, and this is actually about 50% of people with atherosclerotic cardiovascular disease, people with multiple risk factors, the goal is an LDL less than 55. And so that's a pretty hard thing to get to. But as you'll see, the lower the LDL, the better. And then there's no distinction between atherosclerotic cardiovascular disease and no atherosclerotic cardiovascular disease for HDL and triglycerides. So whether you have cardiac disease or not, for men, the HDL we want above 40, women above 50, and for triglycerides less than 150, and ideally even lower than that. And just to remind you, lipoprotein little a can be measured in two ways. It can be measured in milligrams per deciliter, and it can be measured in nanomoles per liter. Nanomoles per liter has become the preferred way to measure lipoprotein little a. But that doesn't mean that if your lab has measured yours in milligrams per deciliter, it's not valid. And so what we tell people is high is high. And so the normal level of LP little a measured in nanomoles per liter would be less than 75 nanomoles per liter. Borderline is 75 to 125 nanomoles per liter, and high is considered greater than 125 nanomoles per liter. If it's measured in milligrams per deciliter, less than 30 is the normal level, 30 to 50 is borderline, and over 50 is high. And one of the things that I talk to people about is sometimes people will get their lipoprotein little a measured more than once. And their lab, where I practice, is Dartmouth. And about 2 years ago, we shifted over to nanomoles per liter. And I have had some people who, for whatever reason, have had their LP little a measured more than once. And it can be pretty scary to have an LP little a measured in milligrams per deciliter, which is usually roughly, half the level as in nanomoles per liter. And so I have gotten some frantic calls, even from some physicians, about the level changing. So it's important to look at those units that your lipoprotein little a was measured in. I showed you this slide last time we spoke, and this really looks at sort of our evolving understanding of how low LDL should be, and also of our understanding that a very low LDL is well tolerated and is healthy. We know that there are people with some genetically very low LDL, and those people just do not get cardiac disease. So back early in my career, the Scandinavian Simvastatin survival study came out. That is this trial here. This took people with cardiac disease and very elevated LDLs, like LDLs in the 190 range. So many of these people probably had familial hypercholesterolemia. And it put them on Simvastatin. And Simvastatin at the time was one of the best statins that we had. We have better statins now, but it dropped the LDL down, to around 125, 130. And it was the first study to show a reduction in not only cardiac events with this statin, but a reduction in all-cause mortality. It was really a groundbreaking study. And so some people said, well, all you have to do is get down to 125. But then all of these additional studies, very large studies, were done. The lipid study, the CARE study, the heart protection study, the Prove It study, the Treat to New Target study, and all these kept pushing the limits. And what we had with the Scandinavian Simvastatin survival study was people on statin or placebo. And over time, it became clear that it was not ethical to put somebody on statin or placebo. The placebo people were missing out on benefit. So over time, as you can see here, the statin was the background drug, and it could be high statin or low statin, as it was in these trials. And the same in Treat to New Targets. That was 10 milligrams of atorvastatin to 80 milligrams of atorvastatin. Then we got into not just high dose statin, low dose statin for Improve It. It was high dose statin, and then one group got ezetimibe and the other group got placebo. So everyone was on a statin. And this showed that getting down even, to around 60 was even, protective. It was you above and beyond the statin. If you were on ezetimibe, you got further protection. And then we got into this trial, the Fourier trial, and there was another one called the Odyssey trial. Those trials used something called PCSK9 inhibitors, and I'll talk about those. These studies were in people with cardiac disease, the Fourier and the Odyssey trial. And patients could be on statins. They were all on background statins. They could be on ezetimibe. And then half the people got a PCSK9 inhibitor. In this case, Fourier, it was evolocumab, which is also known as Repatha, and some of you may be on that, and compared to placebo. but everyone was on their background statin. They started out with an LDL of around 90, and many people ended up with an LDL in the 20s and even teens. And so what we have learned is it's perfectly acceptable to lower the LDL dramatically, and our bodies tolerate that very well. In fact, we like it. So high is bad, average is not good, lower is better, even lower is even better, and the lowest you can get your LDL, the best. And so this is a really interesting thing, because when you think about LDL, or the bad cholesterol, we can drop that LDL to very, very low levels. And we know some people, as I mentioned earlier, have genetically low LDL, and those people don't get into trouble with cardiac disease. This is not the case with other risk factors for cardiac disease. So say, for example, you have high blood pressure. We can't put you on blood pressure medicines that we lower your blood pressure too low, because you'll faint, and even worse, you could die with your if your blood pressure was too low. Same is true for people with diabetes. We cannot knock your blood sugar down to 10 or 15, because that would put you into a situation where you could die. So we are really lucky that we have one risk factor that we can lower dramatically. And the more we lower LDL, the more we reduce cardiovascular events. So here's the data. This is based on data from 170,000 individuals who participated in 26 statin studies, and each typically lasting for about 5 years. What we can say is, if you're on a statin for 5 years, for every 40 milligrams your LDL falls, your cardiac risk falls by 20 to 21%. And we know that there are other agents that can lower LDL cholesterol, like ezetimibe, which we'll talk about, PCSK9 inhibitors, and bempedoic acid. And all of these 3 classes of drugs have cardiovascular outcome trials. So we can say that the same formula holds for all of these medications. So the more you lower LDL with these medicines, the better it is. So let's talk about the available therapies. We are living in a time where we have had a rapid expansion of lipid-lowering medicines. I was a resident when statins first became available in 1987. That's 36 years ago. So I'm dating myself. But our first cholesterol-lowering agents were bile acid sequestrants. And bile acid sequestrants are good agents, but they can only lower LDL modestly. They lower LDL by about 18 to 25%. And those bile acid sequestrants, when they first came on the market, they came on as powders, and you had to take a lot of it, and you had to either mix it with water or mix it with juice, and it tasted like you were drinking sand. And I had lots of people that I started on those medicines who really didn't like me very much. And then luckily, we now have bile acid sequestrants that are in pill form. Cholecibellum is the pill form, and some of you may be on that. That's Welchol. Welchol can lower the LDL, 18 to 25%, but you have to take 6 tablets, and they're rather large tablets. So it was really great. It was a breakthrough when the first statin came on the market in 1987, and that was Mevacor, or lovastatin. And that really revolutionized the therapy. A single pill could lower the LDL quite substantially, 30, 40%. And over the years, we have gotten newer statins. We now have 6 or 7 statins available to us. Almost all are generic, so they're all very cheap. And then it wasn't until 2002 that we got our next class of lipid-lowering agents. And ezetimibe is a class of medicines called cholesterol absorption inhibitors. So while statins block an enzyme called the HMG-CoA reductase enzyme, which prevents you from making cholesterol in your liver, and also actually increases your liver's ability to make LDL receptors. And those LDL receptors can remove LDL cholesterol from the bloodstream. So statins prevent cholesterol production and increase cholesterol removal. Ezetimibe is a cholesterol absorption inhibitor, and it inhibits the absorption from your intestines of both dietary and biliary cholesterol. So cholesterol can come from your diet, but it can also come from your bile. Bile is made from cholesterol. And so ezetimibe works in a different way. It too, though, increases LDL receptors and allows you to remove more LDL cholesterol from the bloodstream. So two complementary mechanisms of action. I'm not going to speak a lot today about lipoprotein apheresis. We use lipoprotein apheresis in people who have what we call refractory high cholesterol. They could have a genetic disorder like familial hypercholesterolemia leading to very elevated LDL cholesterol, or they could have had a cardiovascular event and still have very high cholesterol despite all the medications that they're on. And so lipoprotein apheresis is a procedure that we do, generally speaking, every 2 weeks to help remove LDL from the bloodstream. It's a physical removal of LDL from the bloodstream. And then lomidopide, I'm not going to speak about very much. It's specific only for people who have a very severe form of elevated cholesterol called homozygous familial hypercholesterolemia. So lomidopide was a very important agent. It became available in December of 2012, but really specifically for people with homozygous FH. Alirocumab and evolocumab, you may know these agents as Praluent and Repatha, became available in 2015. These agents are also known as PCSK9 inhibitors. They are monoclonal antibodies, and you can see the last 3 letters, MAB. If you see MAB at the end of a drug name or a generic drug name, that means monoclonal antibody. And so these are monoclonal antibodies that attack PCSK9, which is a protein we all make, and that protein destroys our LDL receptors. So these drugs block that protein and allow us to remove more LDL cholesterol from the bloodstream. They can lower LDL, somewhere around 50-55% above and beyond the statins and ezetimibe. Bempedoic acid is what's called an ATP citrate lyase inhibitor. These agents work in the same pathway as statins, but they work north of statins. And so you stop making as much cholesterol in the blood, in the liver, and you also increase LDL receptors. Bempedoic acid can lower LDL by about 18-25%. And then evonuncumab, notice it has an MAB at the end. And that MAB stands for monoclonal antibody. This is also a drug only for homozygous FH, and it has actually revolutionized the care of individuals with homozygous FH. And but I'm not going to spend a lot of time talking about it tonight because this is a more general conversation. And then finally, our latest addition to the LDL lowering therapies is inclisiran. Inclisiran, like alirocumab and evolocumab, is a PCSK9 inhibitor, but it actually works at the level of messenger RNA. And what you need to know about that is it can prevent the production of PCSK9. So you inhibit the production, and so you end up with more LDL receptors. So what can we expect from these medicines I just discussed? Mary Card spoke with you last week about diet, and that can lower LDL by about 10-15%. Statins, whether they're medium intensity or high intensity, and we'll talk about statins in particular because they're really the base of all of our care for lipids. They're inexpensive and they're very safe, and we have 36 years of data on them. Can lower LDL 35-55, even 60% for some people. Ezetimibe, 18-25%. Those bile acid sequestrants, which are the really earliest agents. And one thing to mention about bile acid sequestrants is these agents do not get into your bloodstream. So the only side, they work in the intestines, and the only potential side effect is a little bit of gas with Welchol. They can be used during pregnancy. So that's an important thing for you to know, and lowers LDL by 18 to 25%. The PCSK9 inhibitors, some are monoclonal antibodies, those MABs, and they can lower LDL 40 to 65%. Inclisiran is what we call a small interfering RNA, can lower LDL by 52%. And these are typically added on top of statins and ezetimibe to get the LDL down further. Bempedoic acid, also known as Nexletol, can lower LDL by 17 to 25%. And then there is a tablet, it's a combination tablet of bempedoic acid and ezetimibe. And while you don't see, ezetimibe is 18 to 25%, bempedoic acid is 17 to 25%, you don't see a 50% reduction, but you see a 38% reduction, and it's a non-statin therapy. So that is something we can use. I do want to point out that statins come in a wide variety. They come as low intensity, moderate intensity, and high intensity. And we typically think when somebody's got cardiovascular disease, the recommendation should be high intensity statins. In people who have familial hypercholesterolemia, the recommendation is high intensity statins. So atorvastatin, either 40 or 80, rosuvastatin, either 20 or 40 milligrams. And so, but not everybody tolerates high intensity statin. And so you can ask the question, do you benefit from low intensity or moderate intensity statin? And the answer is yes. And let's just take atorvastatin, because we talked about that in our conversation earlier today. Atorvastatin at 10 milligrams will lower the LDL by about 38%. When you double the dose to 20 milligrams, you lower the LDL by 44%. That's the rule of sixes. So every time you double the dose, you get an additional 6% lowering. And so you get your greatest LDL reduction from the lowest dose of a statin. But we do think that high intensity statins are important, but that doesn't mean that if you are on a moderate intensity statin, say atorvastatin 10, that you're not gaining benefit. It may mean that you don't get your LDL to goal and that you require additional medications if that's what you tolerate. So statin side effects. If statins do have side effects, and but I think it's important to point out that if I prescribe statins for 100 people, 90 out of the 100 people will have no side effects. That's 90% will have no side effects. And 10 out of 100 will describe some side effects, such as mild muscle or joint pain. And they may describe this as muscle soreness, aches, cramps, fatigue, or even as muscle weakness. But if I look at just those 10 people and I ask, what do I see with those 10 people? 8 out of the 10 with side effects will say, the side effects are very mild and they don't impact their day-to-day life. They may say something to me like, for example, I have a little aching when I first get up in the morning. I'm stiffer than I used to be, but I'm fine in 15 minutes. Well, those people can stay on their statin. 2 out of 10 people will say that they have such severe problems that we need to either reduce the dose or use an alternative medication. Sometimes we go to every other day statins. Sometimes we reduce the dose and continue with daily statin. And then other people will require an alternative medicine. I do want to touch on brain fog as well, but I do want to say that I have a dog that is barking like crazy. And so I am sorry, I'm doing this call from home. I'm just going to step away for 1 second, just bear with me, and put the dog downstairs. This is a 16-year-old dog who sadly is in diapers. So my husband's not home yet, so I'm going to just step away for 1 minute. It makes me seem human. My dog is safely on the couch. So let's talk about another very rare side effect, but I do feel that we need to talk about it because it comes up. It doesn't come up often, but another very rare side effect can be described as brain fog. Now, that is a very vague term. And in my practice, I have had some people complain about this. It's usually people that have very, very intense jobs, people who are engineers, actuaries that need to be crisp and clear. And so, and they need their thinking to be very precise. So it doesn't happen often. I have plenty of engineers who are on 80 milligrams of atorvastatin, but sometimes people will describe this, and we can get around it by, again, reducing the dose, every other day dosing. But there are some people that get this experience and they do require a different alternative. And one of the great things is in 2023, we have multiple medicines. We have ezetimibe, we have PCSK9 inhibitors. You know, the reason we try to focus on statins and ezetimibe primarily are they are generic. So they're very, very inexpensive. PCSK9 inhibitors are fantastic medicines. They have been proven to reduce cardiovascular events, but they are not yet generic, and so they are quite expensive. But, you know, so we have tools, though, that we can use for people. So let's talk about some myths. And I think it's really important to dispel these because in my practice, I often find people saying statins cause diabetes. I can tell you that statins do not cause diabetes, but I can give you the data. Some people who already have higher blood sugar, statins can cause a small increase in blood sugar, and that's been shown in trial after trial. That statins can increase very slightly. So this small increase can move a person from pre-diabetes, which would be described as a fasting blood sugar between 100 and 125 milligrams per deciliter, into the diabetes range, a fasting blood sugar of 126 or higher. So if somebody already was predisposed to diabetes, they had a blood sugar of 125, 124, they could go up to a diabetes range blood sugar, but it does not cause people with normal blood sugar to move into the diabetes range. And remember, we saw the data that for every 40 milligrams you lower your LDL, you can reduce your risk of a cardiovascular event by 21%. And this is true of people who have diabetes and people who don't have diabetes. So we want diabetics. In fact, it's in the guidelines that any diabetic should be on a statin. Next myth, statins can cause liver damage. Statins can lead to a slight increase in liver enzymes, but the risk of liver damage is so low that the Food and Drug Administration no longer recommends routine liver monitoring while on a statin. They say periodic liver testing. And the reason they say periodic liver testing is to leave it up to the clinician. If, for example, someone has had totally normal liver function tests their whole life, and they're on a statin and you've checked them a few times on the statin and they've always been completely normal, you could go to every 2 years of measuring their liver function test when you get a complete blood count or a complete metabolic panel for some other reason. So the FDA wants to leave it up to the clinician because liver damage is exceedingly rare with statins. Next one, statins cause dementia. Statins do not cause dementia. In fact, statins can actually reduce the risk of dementia by lowering your cholesterol significantly and your blood pressure slightly. This reduces your risk of stroke. So if you have a lower blood pressure, if you have a reduced cholesterol, that reduces your risk of stroke. And we know that a lot of people have multiple little strokes. We call it multi-infarct dementia. But if you reduce the risk of stroke, you reduce your risk of dementia. So the next question is what do I do if my LDL is still too high while I'm taking a statin? And the typical approach to lowering LDL is to add therapy onto statins. But we begin with a statin, and depending on the situation and the untreated LDL level, your clinician might start with a low or moderate or high dose statin. If we're starting a child on a statin, and that is recommended for children with heterozygous familial hypercholesterolemia, we begin with a low dose statin. If we're starting someone who's a diabetic that doesn't have other cardiovascular risk factors or just has an elevated LDL, we typically will use a moderate dose statin. If you already have cardiac disease or if you have a genetic cholesterol disorder, you're started on a high dose statin. But if, say, you're started on a low or moderate dose statin and you recheck your cholesterol, or your cholesterol is rechecked about 6 weeks after starting the statin to see where your lipids are 6 to 12 weeks later, and the LDL is still high, still too high for the situation. If someone has no cardiovascular disease, no ASCVD, we want the LDL less than 100. If someone has ASCVD, you want the LDL less than 70 and even less than 55. So say you're on a moderate dose statin and your LDL is still too high. Next step is to increase the dose of the statin to high dose statin. If it's still too high, the next step is to add ezetimibe. These steps, these early steps, are very inexpensive. They're generic drugs that we're using. The next step, if it's still too high, is to add a PCSK9 inhibitor or add bempedoic acid. So either of those two next actions is acceptable. So it isn't enough, though, to just get your LDL to goal, or as we like to say at the Family Heart Foundation, in the safe zone. It's crucial to stay there. We have multiple studies that show that the longer a person remains at goal, the greater the benefit in terms of the reduction in heart attacks and strokes. So you want to get to goal, but you want to keep taking your medicines so that your LDL stays low. Let's move on to triglycerides. We talked about triglycerides previously in my first lecture, and I think Mary Karr talked about triglycerides last week. So what raises triglycerides? Being overweight or obese, consuming too much alcohol, certain dietary fats, and simple carbohydrates in the diet, and lack of exercise. So those are the lifestyle issues that are really important in terms of increasing triglycerides. And then there are certain medicines. So if somebody's on, say, estrogen, we may need to take them off that, may need to use something else. Accutane is something we use for cystic acne. So we're using it in young people, and we monitor triglycerides very closely. Zyprexa, which is used for nausea in oncology, but it's used long-term for schizophrenia. And certain medical conditions that we might need to treat can give way to high triglycerides. So what is the expected triglyceride reduction by treatment? And I said, we're really focusing more on medications today, but I think it's important to talk about lifestyle, because lifestyle can really have a big impact. So restriction of simple carbohydrates, cookies, cakes, pies, ice cream, white potato, white rice, white bread, can really lower the triglycerides by as much as 30%. Alcohol restriction can lower the triglycerides substantially in people that are very sensitive to the impact of triglycerides. Just a quick story. Mary Karr and I worked together in clinic for many, many years, and Mary will know who I'm referring to, but this was a lawyer who wanted to have 2 beers a night. And he wanted to have 2 beers a night, but when he had 2 beers a night, his triglycerides were something like 300. And so, I said, you really probably shouldn't have 2 beers every night. It's not good to have your triglycerides twice normal. And so he said, what if I try exercising? And we found if he exercised between 3 and 5 miles a day, his triglycerides would be normal, even if he had those 2 beers. So that was our deal. He would exercise, and the days he exercised, he could have his beers. Exercise can lower triglycerides quite substantially, and weight loss can be really quite profound. I mean, people who have gastric bypass, people who are on some of these new medications like semaglutide, which is Ozempic, or Wegovy, or tirzepatide. These drugs can really lead to profound weight loss over time and can lower the triglycerides. And then other agents. Statins do have an impact, as we'll see, on triglycerides, lowering triglycerides by 15 to 20%. But nobody thinks of statins as a really triglyceride lowering drug. It has that benefit, but 15 to 20% is typically quite modest. Icosapent-ethyl is a purified form of a omega-3 fatty acid, a purified form of EPA. And it's known as a prescription, it's known as Vascepa. Can give you about a 33% reduction in triglycerides. Gemfibrozol, which is an old fibric acid derivative, it has been on the market since before statins, about a 31% reduction. And fenofibrate is a slightly newer fibric acid derivative. These agents, gemfibrozol and fenofibrate, help metabolize triglyceride-rich lipoproteins. They increase something called lipoprotein lipase, which breaks down triglyceride-rich lipoproteins. And fenofibrate can lower triglycerides 35 to 55%, depending on the dose. And niacin can lower triglycerides 21 to 28%. Higher doses yield higher triglyceride reduction. So the question is, should we strive to lower triglycerides? The answer is absolutely yes, but the data is not as clear as with the LDL story. And a lot of the triglyceride lowering studies, and I'm only going to show you a few, really were done prior to the statin era. So as I mentioned, we see high triglycerides in a number of settings: overweight, obesity, diabetes, lack of exercise, excess alcohol consumption. And we do find triglyceride-rich lipoproteins in atherosclerotic plaques. So that's really important to know. When we look in what is in a plaque, there are some triglyceride-rich proteins. They're called VLDL remnants. And so that's important. And improved lifestyle is probably the most important way we lower triglycerides. Now, very high triglycerides, like over 1,000 milligrams per deciliter, can be seen in the setting of obesity, diabetes, and certain genetic disorders, people who have lipoprotein lipase disorders, and defects in lipoprotein lipase, and ApoC2, they can have defects in those as well. And so these very profound increases in triglycerides can lead to pancreatitis. Pancreatitis is a severe condition. It can actually be fatal. It's your pancreas is right in the center of your abdomen, and when it becomes inflamed, you have pancreatitis. That means inflammation of the pancreas. And lowering triglycerides can reduce the risk of pancreatitis. So this is a case, people who have multiple episodes of pancreatitis, if it's caused, there are lots of causes of pancreatitis, but elevated triglycerides is one of them. Here, medications can be very important, and they play a strong role in reducing the risk. So what do our clinical trials tell us about lowering triglycerides? The VA HIT trial was the Veterans Administration HDL intervention trial. And right there, you know, it's an HDL intervention trial. It decreased cardiac events. The VA HIT trial used gemfibrozol, and gemfibrozol was used at 600 milligrams twice a day in people with cardiac disease. It was before statins were routinely used. So it was gemfibrozol, 600 milligrams twice a day versus placebo. And it lowered both triglycerides and raised HDL. but the decrease in cardiac events was really felt to be related to improving HDL, not lowering triglycerides. And then the FIELD trial. This was a fenofibrate trial in people with cardiovascular disease. In here, fenofibrate, which lowers triglycerides quite significantly, up to 55%, found no benefit in terms of cardiovascular reduction. And then very recently, like in 2022, there was a trial called the PROMINENT trial. And this was a very new fibric acid derivative, pemafibrate, sorry. And this agent, again, no benefit in terms of cardiovascular events. So the drugs that lower triglycerides have not really been shown to dramatically reduce cardiac events. In 2019, the REDUCE-IT trial came out, and the REDUCE-IT trial used icosapent-ethyl. That is a purified omega-3 fatty acid in patients with atherosclerotic cardiovascular disease or diabetes who had triglycerides from 135 to 500 milligrams and well-controlled LDL. Their LDL was around 70. It led to a reduction in cardiac events by 25%. But again, the triglyceride reduction didn't fully explain the benefit. It may have explained some of it, but the benefit might also have been related to the anti-inflammatory effects of the icosapent-ethyl. So with triglycerides, the story is not nearly as crisp and as clean as with LDL. Let's talk a little bit about HDL. So let's talk about what the expected reduction in lipids or increase in HDL is with certain things. So diet can be quite variable, and I'm sure Mary Card talked about that last week. Weight loss is an interesting thing. Weight loss ultimately improves your HDL, but as people are actively losing weight, their HDL, their protective cholesterol, may decrease. And so I always tell people, if you are following the diet that Mary Card has outlined for you, and you've lost 10 pounds by the time I see you again, if your HDL goes down, and I tell them, I warn them about this beforehand, said don't be discouraged, because if you stabilize at a new weight, your HDL will increase after this transient dip. Smoking cessation. This is the first time we've talked about smoking cessation in this talk tonight. Smoking cessation doesn't materially change other lipids. It makes LDL less oxidized when you quit smoking, and oxidized LDL is not good. But in terms of changing the actual number, smoking cessation raises HDL, and it can raise HDL by as much as 10%. So it's really quite powerful. It's a very strong reason to quit smoking. Other agents like statins have only a minimal effect on HDL, 3 or 4% increase. Gemfibrozol is about a 6% increase, fenofibrate a 10 to 22% increase, and niacin about an 18 to 22% increase in HDL. So what about studies that looked to raising HDL? The Coronary Drug Project was actually one of the oldest clinical trials on record for lipids. And it was so old that it only included men. We didn't bother to include women in it. So in this study, men with cardiovascular disease were treated with niacin, and it was about a 5 or 6 year trial, and there was no benefit of niacin during the trial, but they kept following these people out. And after 11 years, it appeared that the people who received niacin during the trial, even if they didn't continue with it, actually had a benefit in terms of a heart attack reduction. But the caveat here is that niacin, the Coronary Drug Project used niacin in the pre-statin era. So we'll talk a little bit later about adding niacin to statins. And it's really a mixed bag. It doesn't look like adding niacin to a person. Adding niacin, if somebody's LDL is really well controlled, doesn't seem to do much. So we'll talk about that in a moment when we talk about the AIM-HIGH trial. The VA HIT trial, the Veterans Administration HDL trial, There was a benefit of gemfibrozol on cardiac events. The benefit was modest, and gemfibrozol can't be used in conjunction with most statins. So gemfibrozol, first of all, it's a twice-a-day drug, 600 milligrams twice a day. That already makes it hard to remember to take. And gemfibrozol can increase the risk of severe muscle side effects on a statin. So we don't routinely use gemfibrozol with a statin. And we're going to talk about CETP inhibitor trials in a little while. But CETP stands for cholesterol ester transfer protein. And there were 4 CETP inhibitor trials. They were all failures. They raised HDL quite substantially. But we want to stay tuned for data from obistrapib. Obistrapib is a cholesterol ester transfer protein inhibitor that is in clinical trials now, and it may behave a little bit differently than the earlier ones. So again, most of our data for improved benefit and reduction in cardiovascular risk from lipid-lowering agents comes from agents that lower LDL as opposed to those that raise HDL or lower triglycerides. Let's talk a little bit about lipoprotein(a). So lipoprotein(a), as you know, is a genetic lipoprotein. Your level is determined by the level of each of your parents because they each give you a gene for Lp(a). And Lp(a) is a very strong genetic risk factor for cardiac disease. Unfortunately, at this moment in time, other than something called lipoprotein apheresis, we don't really have any agents approved to lower lipoprotein(a). And so some people say, even some physicians say, why would you measure lipoprotein(a) if you can't do anything about it? Well, one thing we know is if we measure lipoprotein(a) and say in this particular study, it was measured in milligrams per deciliter. Remember, I said the preferred way is to measure in nanomoles per liter, but in milligrams per deciliter, 50 milligrams per deciliter is elevated. And in this study, the EPIC Norfolk study of 14,000 individuals, those individuals who had Lp(a) greater than 50 were followed for 11 and a half years. And what was found was individuals with high Lp(a) but few cardiac risk factors were 66% at 66% lower risk for a cardiac event versus those with multiple risk factors. And the risk factors that were looked at were typical: smoking, overweight, diabetes, hypertension, high cholesterol, physical inactivity, and an unhealthy diet. So if we measure your lipoprotein(a) and we find that it's high, we are really going to want to push you, and you're going to want to push yourself to get rid of all your other risk factors. You can, just by doing that, getting rid of all your other risk factors, you can reduce your risk quite substantially. Another thing that measuring lipoprotein(a) will tell you, if your level is elevated, it tells you that you do have some increased cardiovascular risk. And one of our advocates, the Family Heart Foundation, has Lp(a) and FH advocates, and we now call them ambassadors. But one of our ambassadors, she was in her 40s, and she had a cardiac event. She had a heart attack. She had a very serious heart attack. She had a family history of cardiac disease. Her dad had an early cardiac event, but she actually attributed his early cardiac event to his type A personality. And, type A personality could increase your risk, but that's not really what increases the risk. But that was the family lore, that was his type A personality. She's 41 years old or 40 something years old and has crushing chest pain. She thinks she's having a panic attack. And it wasn't until after 16 hours when her husband said, you're not looking good. You need to go to the emergency room. This is not, your standard panic attack, that she was found to have a heart attack. And then subsequently, she had a pretty astute new primary care doctor. And that primary care doctor said, this is not right. You really don't have a lot of risk factors. I think we're going to have to check your lipoprotein(a). And lo and behold, she had an extremely high lipoprotein(a). And one of the things she told us at the Family Heart Foundation was, she said, If I had known I had a really high Lp(a), I would have taken my chest pain seriously. I wouldn't have thought it was a panic attack. I would have gone to the emergency room earlier. So just for that information, it's really worthwhile to know what your lipoprotein(a) is. And we think everybody should be screened. So if somebody has a high Lp(a), right now, since we don't have medicines, but hopefully we will soon, it's going to be important for people to achieve their LDL goals. Your Lp(a) is high, lower your LDL so you can reduce your risk. Remember, you can lower your LDL down to 19, 20, and you want to lower the LDL and maintain the LDL at that low level. Achieving and maintaining your LDL can dramatically reduce a person's risk of heart attack or stroke, even in the setting of high Lp(a). We saw that just in the last slide with the EPIC Norfolk trial. And now finally, we're not in the habit of giving medical advice, but in my clinic, if somebody has a very high Lp(a), even though in large part the movement has been toward not recommending routine use of aspirin to protect against a cardiac event, for people who have high Lp(a), they may have an increased risk of clotting. And so most lipid specialists, and you would need to discuss this with your primary care doctor or your cardiologist, but most people in my field in lipid metabolism would recommend somebody with a high Lp(a) take a baby aspirin if they can tolerate it. You know, some people don't tolerate it due to GI distress or significant bruising, but that is one thing we do consider in my clinic. So what is the impact of agents agents that we use for LDL on Lp(a)? Diet has really no impact. And although saturated fat may lower Lp(a) slightly, but it's not recommended because saturated fat will raise your LDL. Niacin can lower Lp(a) by about 20%, but we're going to talk some more about it on the follow-up slides. Statins may, in some people, not in everybody, but in some people, statins may raise Lp(a), but the benefit of statins far outweighs this tiny little increase of 10%. So remember, statins, for every 40 milligrams you lower your LDL with statins, you reduce your risk by 21% of cardiac disease. Ezetimibe and bempedoic acid have no impact on Lp(a). PCSK9 inhibitors, that alirocumab, evolocumab, so Praluent, Repatha, and inclisiran, which is Leqvio, can all lower the Lp(a) by 15 to 25%. But as we'll see, it's not FDA approved for that purpose. And estrogen can lower Lp(a) as well, but we'll talk about that. So estrogen does lower Lp(a), but data from the Heart and Estrogen Progesterone Replacement Study, or HERS study, which was secondary prevention, meaning it was in people with who already had vascular disease, ASCVD, and in the Women's Health Initiative, which was primary prevention, people who had not yet had a cardiac event, found that hormone replacement therapy increased other adverse events like breast cancer and thrombosis. So we don't routinely recommend estrogen as a way to lower Lp(a). Niacin is controversial. Niacin can lower Lp(a) by about 20%. But one important study in terms of cardiovascular risk reduction found no cardiovascular risk reduction. So the AIM-HIGH trial was a trial where everyone was on background statins, and half the people got niacin and half the people got placebo. And even in the group of people who had high Lp(a), niacin didn't have any cardiovascular protection. So it's not clear whether niacin should be used. It's a modest lowering of Lp(a), 20%. And I don't routinely use it, but I can tell you that there are some lipid specialists who do. But niacin also has some other baggage. It can increase blood sugar. It can cause GI bleeding in people who are susceptible, and it can increase the risk of gout. And the PCSK9 inhibitors, alirocumab and evolocumab, lower Lp(a) by 15 to 25%. Inclisiran lowers Lp(a) by about 18 to 22%. And in the two major cardiovascular studies, Fourier and Odyssey outcomes, in both of these studies, Lp(a) reduction appeared to contribute to the ability of these agents to reduce cardiac events. But nonetheless, the FDA has not yet approved PCSK9 inhibitors for Lp(a) reduction. So let's talk about new therapies. We're just going to go through them quickly for LDL, for Lp(a), and triglycerides, and HDL. These therapies are in clinical trials right now. And we, at the Family Heart Foundation, we strongly encourage people to, consider clinical trials, because those clinical trials get us new medicines. But these are being evaluated by the Food and Drug Administration. So therapies for LDL. So all of the PCSK9 inhibitors that I talked about earlier, the Repatha, the Praluent, the Leqvio, those agents are all injectable meds. So there is now an oral PCSK9 inhibitor in clinical trials. And so we wait for the results of that. It's early days with this. The cholesterol ester transfer protein inhibitor, obicetrapib, that I talked about, is 10 milligrams a day. It's an oral agent. This is an agent that lowers LDL by 50%, raises HDL by 165%, and lowers Lp(a) by about 56%. This has a different profile than some of the 4 failed CETP inhibitors. So we wait to see what the cardiovascular outcome trials will tell us. This the company that makes obicetrapib is doing a cardiovascular outcome trial in people with cardiac disease. And so that will be a very important trial. It should be available to us, the results, in 3 or 4 years. I am sure many people who are listening to me tonight heard about gene therapy. We just happened to come from the American Heart Association meetings. I was there this weekend in Philadelphia. CRISPR technology was, sort of all the buzz. CRISPR technology can actually alter DNA. So we think of it as an eraser and a pencil. You can erase one portion, one letter in a DNA code, and replace it with another one, and you make that gene that you've done this to non-functional. And so for people with really what we call refractory familial hypercholesterolemia, it's a very small study in individuals with familial hypercholesterolemia and atherosclerotic cardiovascular disease, where the DNA for the PCSK9 gene was altered. It was altered by a company called Verve Therapeutics, and they reported on a group of 10 adults with FH. A single change in the gene has resulted in a reduction in LDL by 35 to 55%. And just that one change has lasted for 6 months. I say stay tuned because we think that it may be long lasting, years and years, forever. And before this first in human studies, Verve did the same change in PCSK9 gene to non-human primates. And those non-human primates are now out close to 2 years, and they still have this tremendous reduction in LDL. So this won't be used for everybody. It's, the FDA is going to want to monitor this information or these trials because it's the first time we would have altered somebody's genetic code, their DNA. We have lots of studies for lipoprotein(a). Some are further along than others. So pelacarsen is a monthly injection that is being used. So the study is a trial called the Horizon trial. People who have cardiovascular disease have to have their LDL, or generally have their LDL very well controlled with statin therapy, other therapies, PCSK9 inhibitors, ezetimibe. But then half the people get pelacarsen and half the people get placebo. And we believe pelacarsen may lower Lp(a) by about 80%. This study has been fully enrolled for almost 2 years now. And so we expect the results in another couple of years. If this drug proves safe and effective, it will be approved for Lp(a) reduction. Olpasiran is another agent. It is what we call a small interfering RNA. It's like inclisiran in terms of the way it functions. And it is in clinical trials right now in a cardiovascular outcome trial. Again, people can be on statins, they can be on ezetimibe, they can be on PCSK9 inhibitors. They have to have cardiac disease, and they would get this injection every 3 months. Silence Therapeutics has another small interfering RNA. It's early days, so we don't know about the frequency of the dosing. Molbapalin is an oral agent that will lower Lp(a). This actually interferes with the production of Lp(a). And then at the AHA meeting this past weekend, lepodisiran is an injection. Again, they just presented what was phase 1 data, so we don't know yet how frequently this injection will occur. But these, we have now 5 shots on goal for an Lp(a) agent. And so we're very hopeful that we'll be able to offer people who have very high Lp(a) some form of therapy in the future. Agents for lowering triglycerides. Olezarsen improves the breakdown of triglyceride-rich lipoproteins and the clearance of those same proteins. ARO-ApoC3 does the same, and LY3561774 improves the removal of triglyceride-rich proteins from the blood. So these are all in clinical trials now, and we'll see what happens. The very last thing I want to talk about, and it's really important to talk about this, is supplements. Supplements are a $50 billion industry in the United States, and a lot of them don't work. And they're not regulated by the Food and Drug Administration. They're actually regulated by the Federal Trade Commission. And there are not a lot of checks and balances on the quality of the supplements. So that's important for people to know. So we want to ask, how do supplements compare to really low-dose statin, rosuvastatin at its lowest dose, 5 milligrams, in terms of lowering LDL, triglycerides, and HDL? And what I'm going to show you next are 3 slides on comparing rosuvastatin to a number of commonly used supplements for cholesterol reduction. And these commonly used supplements are a big business. So let's look. So this was a study done through the Cleveland Clinic, a very reputable organization, a famous hospital, and it looked at 199 adults ages 40 to 75, 190 completed, so almost all of them had LDL levels between 70 and 189. And they compared rosuvastatin, 5 milligrams, the lowest dose of rosuvastatin, to placebo, to Nature Made fish oil, to Nutriflare brand cinnamon, to Garlic, which has commercials all the time, brand garlic, BioSchwartz brand turmeric, Nature Made Cholesterol, which are plant sterols, and Azero Nutrition brand red yeast rice. Red yeast rice is commonly used for LDL reduction. So let's see what happens here. This is after 28 days, and you can see the full effect of statins, see the full effect of the supplements in that length of time. So rosuvastatin, 38% reduction on the lowest dose. Placebo got a little reduction, and that's just, we all have some up and down of our levels. Fish oil lowered LDL by 3.4%. Cinnamon did nothing. Garlic actually significantly raised cholesterol. Turmeric, nothing much. Plant sterols, as we would expect, the plant sterols are known to lower LDL, but the supplement commercials would suggest more like 10 or 15%, and this was 4.4%, and red yeast rice 6.6%. So none of these supplements hold a candle. And I would just say these supplements are more expensive than rosuvastatin. What about triglycerides? Now, statins are not major triglyceride drugs, which we talked about earlier. The rosuvastatin went down, the triglycerides went down by almost 20%, so 19%. Placebo minus 1.4%. Fish oil is known to lower triglycerides, but this fish oil is not a prescription grade fish oil. And so the Vascepa that I talked about earlier with a 31% reduction in triglycerides is a really much more potent than this over-the-counter one. Cinnamon actually raised triglycerides. Garlic lowered a little, and then the others were pretty minimal. And then nothing does much to HDL. So there was no real difference in what statins do compared to any of the supplements. So I am going to end here. We had a recap of what lipid levels should be at. We talked about the management of LDL, triglycerides, low HDL, and elevated Lp(a). And we talked about drugs that are in clinical trials right now. And I will tell you, there's lots of action in the clinical trial front. And then we talked about supplements, because I think that's something that people really need to think clearly about, whether the benefits are really to take your statin or take your ezetimibe or your PCSK9 inhibitor versus supplements. So I'm going to end here, and I'm hopeful that let's see. Oh, I think we have a few slides that Eric is going to go back through. So I'm
just have a couple of wrap-up slides, and then we'll get into the number of great questions that were put in the chat. So just a reminder, session 4, the final session, is not next week. We don't want to have you calling in on your evening before Thanksgiving. So the next session will be November 29th, so 2 weeks from tonight. And that's going to be focused more on how to make the most of a doctor's visit. Next slide. And again, we have a lot of great resources on our LDL Safe Zone webpage, so please check that out at ldlsafezone.org. It has more basic information of some of the stuff we've been covering in this masterclass, but there's some excellent information there, so I encourage you to check that out. Next slide. And again, if you have any questions specific to your personal care, please reach out to us through Care Navigation. We can really help support you and give you additional resources, really for anywhere you are in your journey, whether you're just coming to start treating your cholesterol, you've been trying a bunch of things, like whatever you need, don't hesitate to reach out to us at familyheart.org/care. Next slide. And again, we really appreciate donations here. We are a nonprofit, so if you've been enjoying this masterclass and you feel like helping support our mission here at the Family Heart Foundation, you can do that at familyheart.org/donate. Next slide. All right, so let me dive into some of these questions.